morning, everybody. We are fortunate to have Dr. Davida Schiff as our keynote speaker today. Dr. Schiff is a pediatrician, addiction medicine physician, and health services researcher who is focused on improving care for families impacted by substance use disorder. She's the director of perinatal and family-based substance use disorder care at Massachusetts General Hospital, where she founded the Hope Clinic, which is a multidisciplinary program caring for pregnant and parenting people with substance use disorder and their families from the time of conception through 2 years postpartum. Her talk today is titled Clinical Utility of Perinatal Toxicology Testing. And I'll turn it over to you, Dr. Schiff.
Thank you guys so much. Can you hear me okay? Okay, it is such a treat to be here amongst many people who have admired their work and what your state has done. And I'm really a privilege to see the collaboration that you guys have done over the past several years where you're at as a state. And I'm thrilled to be able to talk with you about a topic that has increasingly become more popular, the clinical utility of perinatal toxicology testing. Okay. I have no financial disclosures to report. I have several objectives that I hope that you'll get from this talk. The first is just to set the groundwork around some language with respect to screening testing and then the consequences that often come with regarding reporting for perinatal substance use, to understand the unique social and legal consequences that happens with respect to perinatal toxicology testing that's different than in the outside substance use treatment space if you're not a pregnant or parenting person, to review principles of obtaining and documenting consent for toxicology testing, to describe the prevalence of disparities when using perinatal toxicology testing, and then identify clinical scenarios where specifically neonatal toxicology testing can improve clinical management, and then advocate for evidence-informed equity-based toxicology guidelines for newborns. Before I do that, I've been starting most of my talks with a kind of set of grounding principles that I've adapted from a mentor of mine, Dr. Mishka Triplin. I want to acknowledge that it's often complicated when we talk about pregnant and parenting people who use drugs, but I come to this table and I know that all of you do, with a set of values that parents who use drugs should be treated with dignity and respect when they seek care for themselves and their children. An acknowledgement that parenting is hard for all of us, and non-punitive approaches that allow the parent-infant dyad and family to thrive should be promoted, and that really child safety is everyone's responsibility, not just that of our child protective services colleagues. So I'm going to start with a case, and this is a case that will bring me back 10 years ago when I was a pediatric resident. So this is a case of a 27-year-old Black woman who's a G2, P1-2, who's just delivered. She has a history of a stimulant and opioid use disorder, who's in sustained remission on methadone, but had a positive immunoassay toxicology test 6 weeks before delivery for amphetamines. The parent does not endorse any non-prescribed use at that time. There was a vaginal delivery at full term at 39 weeks, and the boy was born with good APGARs. The mom was motivated to breastfeed as she had heard it could reduce the severity of neonatal opioid withdrawal. At that time, in 2013, the hospital policy was to not support breastfeeding for dyads who had any third trimester use or use up to 10 weeks before delivery. This parent was quite motivated, and she chose to breastfeed her newborn despite that hospital policy, and Child Protective Services was called. At that point, they separated mom and baby, and that baby was discharged home in foster care after a prolonged course of pharmacologic treatment for neonatal opioid withdrawal syndrome, for which the mom was not allowed to visit the newborn's bedside. This case left me as a pediatric trainee at that time with so many questions, and really I think has informed much of the work that I've done over the past decade that I'm excited to share with you in the rest of this talk. But specifically, what was the evidence around that breastfeeding guideline that we had used? How frequently are toxicology tests actually false positives? What really is the clinical utility of that test, specifically in the perinatal period? Did that mom actually harm their infant by offering him breast milk at that time? Would the same result have happened if this patient was not Black? And really, most importantly, how could all of this be prevented? to support the health of the mother-infant dyad. All right, I'm going to back us up and we're going to go through some key definitions, some terminology, and then we'll get back to the case at the end. So when we talk about screening, we're talking about the use of a validated screening instrument or therapeutic dialogue to elicit information about substance use. You may do this in your hospital setting with things like the NIDA Quick Screen or the Audit C, the 4Ps or CERP or specific to pregnancy. But we're really talking about either a verbal or written tool to ask patients about their substance use. Toxicology testing is the collection of some type of bodily fluid, whether that's urine, serum, meconium, hair, to measure or capture the presence of substances and or the metabolites that are present at a particular point in time. And then reporting is a referral to Child Protective Services for a concern for abuse and neglect. I say this because you will often hear people describe urine drug testing as screening, but I want to differentiate the two because when we hear what our professional societies recommend with respect to substance use screening and testing, they're quite different. And I think these are important to put together because often testing, which will be the focus of our talk today, really is seen as one decision point on the pathway that often results in child abuse and neglect reporting. So by way of some common types of perinatal toxicology testing, for newborns, you most commonly will see urine, meconium, and umbilical cord testing. You can see the year that they were developed. I think what I want to focus on here is the window of detection. So urine will typically detect small 72 to 96 hour windows of last use, whereas meconium and umbilical cord will measure long windows of gestation, long windows of detection up to the early second trimester. And so just some key points about toxicology testing to make. As I said, urine toxicology testing measures recent-ish exposure. The most important thing here to note is that if you're using an immunoassay that measures for cannabis and fentanyl, the metabolites can linger for weeks. We can show some scenarios of that later on if it's helpful. That most urine tests, as was the example in the case that I shared at the start of this talk, are quick cup or immunoassays. Those should not be considered definitive, and always those results should be sent for confirmatory testing due to high rates of false positives in certain assays. Many umbilical cord and meconium testing results do not come back until after the newborn has been discharged. I understand in your state, you guys have done some work in partnering with labs to reduce the time for cord testing to come back. In our hospital system, it doesn't come back for about 7 days. But I really want you to kind of highlight these last two pieces, that testing does not quantify the dose, frequency, or duration of exposure, or if a parent has a substance use disorder. And that finally, a toxicology test is not a parenting test. Okay, so why are so many hospital systems and state perinatal quality collaboratives reevaluating their perinatal toxicology approaches now? What I'd like to do in the next section is sort of lay out, I think that this is happening at this moment for 3 reasons. One is an understanding of the prevalence of inequities in toxicology testing. The second is an acknowledgement that despite recommendations around informed consent, that practices are suboptimal or lacking. And the third is data emerging that's highlighting limited utility in certain commonly invoked indications for testing. And I'll go through each of those now. So there is a long-standing history of how toxicology testing is inequitably utilized. This is data from our hospital network across the birthing hospitals affiliated with the Mass General Brigham system, where we showed specifically for individuals without a substance use disorder, as we think that those are often being individuals who are being tested for some of the commonly used indications like obstetrical complications or social history or risk. You can see stark disparities by race and ethnicity, but also by age, where younger individuals are more likely to be tested. Again, Black, Hispanic, or mixed race individuals are more likely to be tested than white individuals. And then those on public insurance are much more likely to be tested than those receiving private or commercial insurance. This has been replicated in several hospital systems recently. This is a paper from a study out of the University of Michigan, where they looked at the trends over time in the numbers of newborns born to Black birthing people, and found that they were significantly more likely to be toxicology tested compared to newborns born to white birthing individuals. Similarly, there were disproportionate toxicology testing and CPS reporting practices that were found in a California NICU. As you can see here, that Black individuals had 3 times the odds of our CPS referral and twice the odds of an infant toxicology test. So now thinking a little bit about consent for toxicology testing, we have clear guidelines from almost all major professional organizations that stipulate informed consent should be obtained prior to toxicology testing in pregnancy. This actually went as high as the United States Supreme Court in Charlestown versus City of Ferguson in 2001. And really every major professional organization, including the American College of Obstetrics and Gynecology, the American Academy of Pediatrics, the Society for Maternal Fetal Medicine, and the American Society of Addiction Medicine, has weighed in and stated that informed consent and written informed consent for several of those is preferred. So what we did using that same birthing hospital network across Mass General Brigham looked at how often we were doing this. So in our hospital network, several of the hospitals had specific policies that recommended consent. Our state actually has a guideline that recommends consent, and we wanted to see how we were doing. I thought it was really notable that verbal consent was documented in less than a third of the cases across a 4-year time period at five birthing hospitals in Massachusetts. And we were pretty generous, where really anybody even who mentioned toxicology testing in their note that they discussed it with the patient was described as verbal consent, whereas arguably that is not really meeting the sufficient standards of consent. Just to lest any of the sort of newborn folks in the room think that they were doing any better job than the birthing people, this is a random sample of a smaller cohort and subset with it, just the Mass General Hospital where I work, and you can see basically a very similar number, where only a quarter of those charts had documented consent. So what are the components of informed consent, and why does this matter? Our professional societies have describe the components of informed consent to be explicit clarification for both the provider and the patient about the goal of testing, a discussion of who will have access to the results, a review of the ramifications of a positive test, and an ability for the person to refuse the test, and setting the limits and refusals for someone like a minor. And that the American College of Obstetrics and Gynecology and ASAM have also highlighted that written consent is preferred for accountability as an educational tool and patient preference. So we have a paper that's under review where Dr. Leah Schwartz, as a medical student, did a really beautiful qualitative study where she looked at the perceptions of 25 prenatal clinicians, including midwives, residents, and OBGYNs, and 15 patients at 2 birthing hospitals in Massachusetts to understand their perspectives on consent. And really, she found that the current consent practices often deviate from the normative standards for information disclosure in obstetrics. And I want to read you a couple quotes. So one clinician said, I think the consent for other things is a bit more robust in terms of talking about the risks of testing. I wouldn't say we're very detailed, whereas for a procedure, we're obviously covering the risks and benefits in more detail. It's more of a getting permission to do the test. A patient said, I guess maybe instead of just a drive-by, hey, we're going to do this, is that okay? Actually explain why they're doing it. When you get a flu vaccine, they give you a handout that says what they're doing. Here are the ingredients, and it's something like a handout consent form for what we're doing, why we're doing it, and making sure that you're okay with it and what happens when we get the results back. And then there was also this perception that consent conversations lacked voluntariness, that patients felt unable to decline testing due to fears of Child Protective Services involvement and perceived pressure from clinicians. So one patient said, I was so scared about even the possibility of a case being open. Like, what if I say something wrong and the CPS worker thinks I'm suspicious? Or what if my husband talks too much? I felt like I couldn't say no because of what could happen. And what if this was the only thing hinging on them not opening a case? a clinician said it's inappropriate and I think borders on illegal in a lot of circumstances. And that may sound dramatic, but if we're saying we need to be consenting this patient for this test, which I do strongly believe, I think the consents we're doing are not appropriate and they're not true consents. I don't think the patient feels empowered to say no. And now to that third box around utility of toxicology testing. So again, I'm going to highlight some work that we've done with our team. This is, again, deliveries. So 60,000 deliveries across 5 Mass General Brigham birthing hospitals between April of 2016 to April of 2020. So as you can see, we had 3% of dyads who received either a maternal or infant test. 9% of those had an unexpected positive toxicology test for any non-prescribed substance. We removed unexpected positives for cannabis only, as it was legal in our state for recreational use during this time. And so that left us with 80, or about 4% of toxicology tests that were unexpected for a non-prescribed substance other than cannabis. Then what we did is we stratified these unexpected positive results by the clinical rationale for the test. And we sorted them and we made this up into high, medium, and low yield indications. And so the cutoffs that we have here for high, medium, and low are arbitrary. But we essentially made 2.5% the cutoff for high yield, and then low yield being no unexpected positives. And the other thing that's really important to highlight about this chart is that these are mutually exclusive categories. So if you had somebody with a history of a recent substance use disorder who also used cannabis and had an infant who was jittery, they show up in this bucket. But what we found is that there were clear clinical indications, specifically ones that are commonly invoked, like maternal medical indications, that had much lower rates of unexpected positive drug testing. So I'm going to focus here a little bit on newborns. What are the reasons to perform a newborn toxicology test? Does it benefit the patient? Does it change our anticipatory guidance? And I think I put this in gray because we, as a team of newborn clinicians in this space, I think have a lot more thinking to do around whether the utility of toxicology testing to change or inform the need for social worker or child protective services is an appropriate indication or use of a test. So a little bit more data. This is a paper that looked at meconium and umbilical cord testing and how well it correlated with clinically diagnosed neonatal opioid withdrawal syndrome based on ICD-9 diagnosis codes. And the key point that I want to make here is around the sensitivity of the test. So for meconium, there were 35% of all cases of ICD-9 diagnosed neonatal opioid withdrawal syndrome that were opioid negative in meconium toxicology testing. And 21% of all cord tissue tests were negative in the case where there were ICD-9 diagnosis of NOWs. I share this data because I think we're often falsely reassured by negative meconium or cord testing, when actually I think that we're seeing a lot of potential false negatives. And so using this test when somebody has a negative test is saying, okay, there's no risk. Even thinking about kind of applying this to that question around social risk, I think is problematic. This next paper looked at comparing maternal urine drug testing with neonatal clinical outcomes when compared with umbilical cord testing. And so there are 2 findings from the paper that I want to highlight. The first is that maternal toxicology testing had a much higher odds ratio of being associated with a neonatal opioid withdrawal syndrome diagnosis than umbilical cord testing alone, or having both dyads be positive for both maternal and umbilical cord testing. But then I thought what was really interesting here is that there's actually not great agreement between umbilical cord and maternal urine drug testing, where actually specifically the positive agreement between the two was quite low, suggesting that much more information that could potentially guide our clinical management is identified on the maternal testing than umbilical cord testing. Okay, back to the 60,000 deliveries in the Mass General Brigham Hospital Network paper that we published. I wanted to try to understand, when we did have an unexpected toxicology test result, how often did that actually affect our clinical decision-making at delivery? And we came up with 5 categories of types of changes of management that we would see as a result of a positive or unexpected positive toxicology test. The first is it might change our counseling and referral to treatment for women who had a positive, or birthing people who had a positive test at delivery. It could change our neonatal opioid withdrawal syndrome management at time of delivery. It would change our suggestions or recommendations around breastfeeding if there was a positive toxicology test at delivery. And then would it change our CPS reporting or change in parental custody status at discharge? So you can see here, again, these are the highest yield clinical rationales and those medium yield clinical rationales, and then overall. So overall, it did, largely because in the hospital policy at the time, any positive toxicology test at time of delivery was reported to CPS. It did change our CPS reporting. And then in 18 of those cases, out of really 60,000 delivery, we found that an unexpected toxicology result resulted in a custody change at discharge, which is 0.03% of the time. So again, narrowing in here on infant toxicology testing and my role as a newborn provider, pediatric provider, when should newborn toxicology testing be completed is really when it informs our clinical management. So when we have concerns about chronic opiate exposure in utero and there was no screening or testing of the birthing person, it can be helpful in determining the need for the appropriate observation period. Similarly, when you have unexpected symptoms such as withdrawal that could be consistent with neonatal opioid withdrawal syndrome and they're unresponsive to non-pharmacologic care, it could be appropriate to help guide either the recommended pharmacologic intervention or avoid a more invasive workup for neurologic symptoms. Meconium testing, though, and I would argue cord blood testing has really very limited clinical benefit in the era specifically of Eat, Sleep, and Console, which your hospital systems have championed. Successful treatment usually does not hinge on the rapid identification of a specific substance exposure. And yet we really do need more accurate data on substance use during pregnancy as a public health metric, but that isn't contingent on clinically performed biochemical testing. So with kind of going through those 3 buckets around disparities, minimally performed and adequate consent, and then the clinical utility, I want to highlight where our current National Professional Society guidelines are. I'm going to start on the obstetric or OB prenatal providers. So ACOG and SMFM in 2017 and 2019 advocated for universal verbal screening as a first-line tool to diagnose substance use disorder in pregnancy, that urine drug testing should only be undertaken when it benefits outweigh any harms, that there should be consent for urine drug testing, and the explicit criteria for urine drug testing to avoid bias and discrimination. The American Society of Addiction Medicine in 2023, in really addition to affirming the bullets above, added that there should be a right of refusal and that refusing a toxicology test should neither be seen as an indication of use nor detract from clinical care. The confirmatory testing should be utilized, that a positive test is not determinative of a substance use disorder. And then they made these 2 statements around newborn toxicology testing, that parents should be made aware of newborn toxicology testing whenever possible, permission should be obtained, and that infant meconium and umbilical cord testing lack clinical utility and as a result are not recommended. The AAP has actually been a little bit more quiet on this. I am really excited to be working with several colleagues across the country to update one of the Academy statements that's slowly making its way through committees, but we hope in several years we'll have some updated guidance here. But what we have right now really is the neonatal opioid withdrawal syndrome clinical report in 2020 that has 2 statements around infant toxicology testing. The first is pediatricians should be aware of and reduce institutional biases in implementing universal toxicology testing for infants, which could result in unequal consequences for mothers and infants on the basis of race, ethnicity, and/or socioeconomic status. And the second is infant toxicology testing should be completed when it will inform clinical management. In some instances, testing of the infant provides no additional clinical information and would not be recommended. So in this last part of my talk, I want to go through my own kind of journey and our institution's journey in questions that have come up when we've considered the implications of reducing specifically in neonatal toxicology testing. So the first is, what is the value added in obtaining newborn urine toxicology testing in addition to birthing person test at delivery? This is a study that came out of the University of Maryland by Katrina Mark and colleagues, where they had over 1,500 pregnancies where all birthing persons and newborns were tested. So this is a hospital system that universally tests everybody. And after they removed medications that were dispensed during the delivery hospitalization, there was a negative predictive value of 100%, which basically means that if there was no new information that was told that they found on the newborn test that wasn't already identified on the birthing person test. If you have a birthing person test, you're in really good shape with respect to identifying the substances that are in that dyad's system at time of delivery. I think it's notable that the positive predictive value is quite lower, where actually if you had a mom who had a positive test, you have a much lower likelihood of identifying that information if you had a newborn test alone. Okay, so one thing that has come up a lot is if a parent declines a test, does that mean that I, as the provider, should assume that the newborn has been exposed to non-prescribed substances? So in 2022, as a result of some of the published work that I shared with you, our hospital system changed its internal policy at Mass General, where we required written consent for parental birthing person test, as well as infant meconium testing, but infant urine was done by parental assent. So what we have here is the ability to look at the 107 dyads who received any perinatal testing between January of 2022 to December of 2023. We had 45 of them, one with twins, who had only newborn testing. Of those, and again, I just share, we made an assumption here because charts are poorly documented, and we have people sign a consent that they either consent to a test. I think we poorly are describing when people decline consent. So we made the assumption that when the parental testing did not occur, that meant that they had declined testing, which is a fair, someone could argue is sort of an over assumption. We had 45 dyads with only newborn testing here. Of those, we had 38 dyads or 39 newborns with only newborn toxicology test results available. Some of those actually did have testing in an outside hospital. Of those, 92% of those had no unexpected positive results. 3 of those did have results that led to a change in clinical management, and I'll describe those in the next slide. So what do I take from this data? That overall, unexpected results were uncommon in newborn-only tested dyads. But when we look at the indications for why those individuals were tested, no non-prescribed substance use in pregnancy was actually the highest, was the most commonly invoked indication, resulting in a rate of an unexpected positive, and then use of medication to treat opioid use disorder, so a known substance use disorder. But these other clinical presentations for why people were tested, for their newborns being tested, did not necessarily mean when that birthing parent declined that you should default assume that meant that birthing person had some use. So really highlighting that no new information was added in over 90% of these cases. I understand that some of your hospital systems are moving towards an approach where you're actually doing less newborn urine, and hopefully presenting this data can provide some information, at least in a different hospital network, of pretty limited information that was obtained by just those newborn urine cases, and that really birthing people may decline testing for other reasons than concealment of use. I've mentioned Dr. Mishka Turplin. This is a beautiful editorial that he wrote that I wanted to share with you because he describes this concept of epistemic injustice. He describes the harm that comes from not trusting our patients. And this is a long quote, but I'm going to read it to you because I think it's really beautiful. When we listen to the drug test and not to the patient, we perpetuate a mistaken empiricism, one that falsely elevates the value of information collected for measurement over the value of information collected from a person. This is an epistemic injustice, a harm done by devaluing a person's credibility and undermining them as a giver of knowledge. The neglect, silence, and erasure of a patient's voice and perspective harms not only them, but it also harms us as physicians. It deflates us in our capacity to know and to heal. To be blunt, dehumanizing people makes their care environment unsafe, and to expect people to be forthcoming about sensitive and potentially catastrophic information under such circumstances is irrational. So another question that came up for our obstetrical providers when we recommended that there be a hard stop that is placed prior to ordering a toxicology test that says that consent has been obtained. And they said, look, we are in a high stress, very busy environment. This is too many clicks in our electronic medical record. Why do we need this hard stop? And so I want to share with you data, again, post our internal MGH policy change from January 2022 to December of 2023, where we had 60 birthing persons who did have toxicology testing. And then we went back and we saw how many had obtained consent. And so about 2/3 had some type of consent, but only 1/3 of them had written consent. So despite all of this effort, despite our change in our policy that had been informed by that work that we had done looking at data from 2016 to 2020, we actually are not doing that much better in terms of guideline concordant care when we take a look at our birthing people testing. When we come over here and we look at our newborns with meconium toxicology testing, again, our urine under this approach between this time period was only to require written consent for newborn meconium. We have 93% of those that had consent obtained. So felt really good about that kind of QI work that we had done and that implementation effort. But still, only 30% of those were written. So we had some work to do. But I want to show you this run chart where what we did is we looked at meconium toxicology tests at MGH over time. You can see this is our rate of toxicology testing for meconium, or the numbers of meconium toxicology testing before we changed our policy. Interestingly, as we see in so many other QI processes, that as soon as we started talking about this, before we even changed the policy, the rates of testing declined. When we finally updated the clinical guidelines in November of 2021 and kind of went live in January of 2022, you can see lower rates of the number of meconium tests. And then once we had a hard stop, we had an even smaller number of tests that were obtained. And what I don't have here, but what I should have shown you is the number of meconium toxicology tests that were kind of done with guideline concordant consent following that epic stop. So then I think as we come to a place in many hospital systems, certainly in our hospital network, where as clinicians, we are going to be approached with what do we do if a parent declines testing? And I'll tell you, this required some undoing of my training, and a lot of colleagues like Dr. Sharon Oswald-Johns at Yale and Dr. Leela Sarathy here at MGH to help push me and move me in a direction of thinking about how we can inform our clinical decision-making in ways other than a birthing person or an infant toxicology test. And often we have better approaches. So I'm going to go through each of these different scenarios and hope that it helps guide you on that process as well. The first is when we have a concern that a patient presents with an altered mental status, whether it's birthing person or a newborn, it's harder to identify that we really do have supportive management, that most of the treatments for concern for an altered mental status for a birthing person is really supportive. With respect to whether it will aid in our ability to counsel parents and refer them to SUD treatment, really verbal screening is the gold standard, and that should be done universally per the recommendations from ACOG and SMFM. When thinking specifically about the infant, we asked, does it aid in the management of withdrawal symptoms? And I would argue, based on some of the results of looking at comparison of neonatal clinical ICD-9-10 diagnoses, as well as cord and meconium testing, is really we can monitor the infant for its clinical signs and symptoms of neonatal opioid withdrawal syndrome. In fact, you do that, we do that, that's what we do. And that's what our tools, including Eat, Sleep, and Console, has allowed us to be able to do. Will it aid us in the discussion of breastfeeding recommendations? I think that we are moving towards a place of really universal precautions for breastfeeding recommendations, acknowledging and understanding that the Academy of Breastfeeding Medicine is highlighting that breastfeeding is a human right, and that we can, in a shared decision-making conversation with patients, provide universal precautions for them in the setting of a recurrence or return or recent use. I'll share a little bit of some of the work that we've done at MGH in a second. And then finally, and this is state dependent, but does the result aid in meeting mandated reporting requirements? And I'd argue that knowing that a toxicology test doesn't tell us if somebody is a good parent or not, that we should rely and use the full battery of assessments that we have to assess infant safety risks and do psychosocial screening, both in the hospital and outside the hospital settings. So, people ask, is toxicology testing needed to inform anticipatory guidance? Particularly, I think this comes up around the recommendations for human milk. But it's certainly in also around safety considerations in the home, around discussions about safe sleep and other harm reduction strategies. And what I would argue is that we can have all these conversations universally with our patients. In fact, we should be discussing safe sleep and whether a person is on a medication that may be potentially sedating because for other psychiatric conditions, or whether we're concerned about non-prescribed substances. We should be talking about safe storage and safe supply. We should be talking about who might be an alternate caregiver if that person is too sleepy, and making sure that that newborn is going home and sleeping on an independent, safe sleep surface. And then on the right here is an example of the guideline that we've been working on at MGH for talking about what to inform parents so that they are knowledgeable about the benefits of breastfeeding, but also the harms, and that really hoping to empower them so that we're moving towards a culture of shared decision-making to inform breastfeeding decisions, and acknowledging the Academy of Breastfeeding Medicine's position statement that breastfeeding really is a human right. Before I get back to our case, I want to make one plug, particularly for your hospital systems and those who may be also thinking about making reductions in toxicology testing, is that we also need to really carefully track balancing measures. So I'll share with you from, it's actually 2022 to 2023 at our hospital at MGH, there have been no cases of readmission for neonatal opioid withdrawal syndrome that were not known. There was no cases of readmission for intoxication related to breast milk exposure. And there were no readmissions in 30 days for new social concerns or non-accidental trauma or maltreatment or evaluation. But I think we as a community interested in perinatal health have a need to really help hone and refine what are the right balancing measures to track together. So now with that, in the last few minutes, I'm going to get back to our case. This case has, I wouldn't say haunted, but has stuck with me and has really impacted a lot of the work that I've done. So you're going to hear much more about the updated Academy of Breastfeeding Medicine guidelines later today, but I wanted to describe a related but slightly tangential research project that I developed as a result of this case. So in 2015, the ABM really restricted breastfeeding in individuals who had recent substance use. So in 2015, there was support for breastfeeding for substance-exposed dyads if the mother was in a SUD treatment program, if she was receiving consistent prenatal care, had no other medical contraindications to breastfeeding, and had no non-prescribed use for a specified time period prior to delivery. And I know you guys are going to get into this in much more detail, but I was really struck by these time periods where there was a green light to breastfeed if you had no use for 90 days prior to delivery, so no use in that entire third trimester. There was a gray zone of recommendation for kind of a shared risk-benefit conversation with clinicians if there was use in the 30 to 90 days before delivery. And then breastfeeding was not recommended if there had been any use in the month before delivery. So I really wanted to understand why and how useful is that recommendation, knowing the significant benefits to breastfeeding, particularly among opioid-exposed dyads. So when I was a fellow at Boston Medical Center, I did a single-site retrospective cohort study looking at about 500 women who received opioid use disorder treatment at Boston Medical Center's Project Respect. And we found that the results of urine drug testing at delivery had the strongest association with ongoing non-prescribed use postpartum. But that overall, actually, using a urine toxicology test within these windows that the ABM had defined as the categories that we should be basing our breastfeeding recommendations on had pretty poor positive predictive values altogether. And so what we did is we used this paper and we went to the Academy of Breastfeeding Medicine and we said, can we update this position statement or this clinical report? And so I just want to kind of take you on a timeline of what this journey has been like for me over the last decade. For those of you who may be more junior and are sort of thinking about like, is this QI project or is this research project going to make a difference? So again, I'll take you back to early 2014, where that parent lost custody after breastfeeding her infant when she had had a positive toxicology test that may have been a false positive within 90 days of pregnancy. Actually, a great mentor of mine presented a pediatric grand rounds where she actually asked this question: does a toxicology test at delivery actually predict the use of substances post-delivery? And as a young fellow, I was like, I can do that. I can design that study and I can take a look at this. As a junior faculty, I did a bunch of the work around the utility of toxicology testing, around consent and disparities that I presented, leading to our change of our internal policy. And then I won't steal the thunder for the talk that's going to happen later this afternoon, but we are just so excited for these revised guidelines that came out in December of 2023 that will allow, I hope, and really promote the recommendation for increased receipt of breast milk for sepsis-exposed newborns that have not have a positive toxicology test or use at delivery. So I'll summarize some of the conversation that points that I've made and just offer some opportunities for changes you either may wish to make, you are making, or in some cases I know have already made in practice. The first is implementing written consent as part of drug testing protocols in the perinatal period. The second is to take a look at the clinical rationales that are being used for drug testing, to consider the removal of low yield indications, as in data that I didn't share with you, as we see that some of those lower yield indications are the ones that actually are disproportionately invoked for women of color. That we reconsider what information is gained from obtaining a neonatal toxicology test and how does it really help guide our clinical management. And if we can leave with anything, and as you go and you have taken care of your next dyad, asking the question of, will this help guide my clinical management, being a really important takeaway. And then and it sounds like your state is working to roll this out, but to adopt the Academy of Breastfeeding Medicine's updated guidelines that really promote breastfeeding for parents who have not had substance use at time of delivery. Okay, with that, I am going to stop sharing. And it looks like we do have a couple minutes for some questions, and eager to hear your thoughts and reflections. And yeah, open it up to you guys.
And we have probably 15 minutes for Q&A. If anybody would like to come off mute and or come on screen to ask a question verbally, that is certainly welcome. And you can also put your question in the chat.
Yeah, I just heard, can you share the consents that you use and the language that we talk about with for birthing parents and newborns? Absolutely. I will share that. So the policy or guideline change that we had at MGH from 2022 to 2023 has now been superseded by actually a Mass General Brigham-wide new policy change that went live actually last week on April 1st of 2024. And so we will soon have a Mass General Brigham, or we now do have a Mass General Brigham-wide consent, and I'm happy through Adrian or others to get you guys the specific language that we've used. I'll just add one more piece and then go to Brina's question. You ask about the specific language you use with birthing parents. I think this is actually an area that we need to do a lot more work in. I think, there's been so much work in thinking about like how we have discussions about, say, a trial of labor after cesarean and how we counsel patients and have that shared conversation, shared decision-making conversation. There's really nothing around how you really do have this hard conversation, knowing the implications of these toxicology tests. And we have some tools and have some things that have worked, but I still feel like I need more help in the right language and really a validated way to have that conversation so that people don't feel coerced or forced or a false sense of voluntariness. Yeah, Brina, please come off mute.
Thanks so much. I did notice, Molly, your hand's up too. Did you
sorry.
preceded me, or do you?
Oh,
is
I'm
that
sorry,
just-
I missed you.
Hi. Thank you so much for this incredible talk. I have so much churning in my brain, but the one thing top of mind is wondering if you've engaged with your hospital's equity teams or your public health system, wondering about DEI, and just there's so much here about sort of dismantling structural racism in our world, and we're trying so hard in Vermont to make those links, and this seems so concrete. Like this is like the one true effort that is ridiculous and awful.
Yeah, actually, Dr. Allison Bryant and Dr. Sarah Wakeman, who are leaders across the Mass General Brigham team, used that exact point to argue that this was a system-wide priority for equity that needed to be one of the key cross-site, cross our system changes. And it was exactly for those reasons that you just said. So if there's those opportunities across your systems to really argue that this is an equity issue, I think it was very effective for our hospital network to be able to make this change that honestly otherwise was taking years of consensus attempts in decision making, and they were able to use that overarching network in the guise of the stark inequities that we're seeing. Molly.
Yeah, thanks. This was really amazing. And my question is about resistance. Like, I was wondering if you could describe resistance, particularly like at higher leadership levels that you might have encountered, and how you manage that.
Yeah, maybe I'll share with you my own resistance, because I feel like that is a place where I started. I was trained that this was a useful test for me to inform my clinical decision making, and I held on to that the same way we held on to, is this CBC going to be helpful? Is that I to T ratio going to be helpful for me thinking about neonatal sepsis? Like, I wanted that information because I was used to it, not necessarily because it really was the thing that I needed to inform my clinical decision making. So it's been my own journey in really thinking about, why am I using this test? Is this test actually helping me answer the question that I want? And then are there alternate approaches that are likely better and potentially less harmful for answering that same question? As we've made these changes, I think what I have been really focused on is, how do we collect data to help with individuals who are still in various stages of resistance like I was, as we've understand both the positive changes and the potential for harm. And that's where I really do think, as a system, identifying what balancing measures you guys may want to be measuring, and then really measuring them, because those are the things where people are saying resistance. The biggest resistance that I think we get on the neonatal side of things is, I'm going to send a baby home that's going to be harmed. And no one wants that to happen. And probably all of us who take care of high-risk newborns have had some terrible outcome that has happened, where a baby, despite everybody's effort, has had an unwanted, undesired outcome, right? Whether that's related to a toxicology tested delivery or not is something we need to tease apart, and then really think about, what are the opportunities for supporting those families after delivery. So if we're not putting all of our time and energy into this toxicology test and an evaluation at birth because it wasn't necessary at that moment, how do we support the families when we know there are real risks and needs after delivery? I don't know, does that answer your question? Let's see. Do you recommend providers obtain consent for nursing? Oh, this is a really good question. I think this could be this, in our hospital system, it is the clinician of record. So the provider is the one that has the consent conversation. And what I will tell you is happening before this is nursing would say, okay, put a bag on the baby, okay, get a urine, and then like maybe a conversation happened and maybe it didn't. And so that hard stop where the order can no longer be ordered and routed to a clinician who comes the next day and is signing a whole bunch of urine orders, but actually has to have the who's had the consent conversation has been really helpful in making sure that those conversations actually happen. I don't think that nurses don't have the skills to have that conversation. I think that they really could, and it may be dependent on the structure and setup in your birthing hospital system and as to whether they're the right people or not.
Jennifer, feel free to come off mute.
Oops, still muted.
You would think after like 4 years of doing Zoom meetings. Yeah. So anyway, I'm thinking kind of tacking onto Brina's comment and question. I'm thinking also about training both, MAs, LNAs, and then throughout the whole clinic, potentially also admin folks, thinking about how I'm at Central Vermont Medical Center. We've had some trainings around harm reduction. It was like a great start to have conversation and introduce harm reduction kits, and just our staff seemed really open to it. But then it's like, how do we make the time? What are other training opportunities? Everyone can obviously and need to educate ourselves, but as teams, how are you finding fitting that in with the busyness of a clinic? Yeah. Thank you.
Yeah, I'll reflect a little bit on our MGH implementation of our policy from 2022 to 2023, where we spent a year trying to come up with this policy, like a year of almost weekly discussions. And then we got to this place through a consensus-driven approach that maybe nobody was actually happy with, but that's where we got because that was the goal, was consensus. And then we implemented it and we kind of did a crummy job, right? And so I'm just like validating how important it is, even if you get to the place where you have a new approach, if you don't implement it and you don't train and you don't have the sort of time and space to really roll out these new guidelines or policies, then you're not going to make the changes that you want. So I think having your teams be in spaces like this, I really appreciate the way in which VCHIP has kind of created a space after this conversation for you guys to, in smaller teams, sort of discuss questions, reflections, worries, fears, and what that might look like. And I might pose that could be something in those smaller settings you guys talk to each other about in your specific, state and hospital network. What would training look like? What is it needed if you were to make some changes to reduce the use of toxicology testing? Who needs to hear some of the components of data to inform these decision makings? Who needs to sort of hear and understand some of the conversations around how to do consent? And so, yeah, that requires time and that requires investment from hospitals. And I feel like I've also learned a lot from the way in which the new Mass General Brigham rollout policy has happened, where it's kind of come much more not as a consensus-driven year-long process, but that like this is the new policy and now you have to roll it out. And these are the tools that you need to sort of implement it. And that's a very different approach. And it's now being, rolled out across a much larger, wider hospital network. And so we're excited to sort of see what happens over the next couple of years too. Hope that answered some of your question.
We have about 5 more minutes in the large group if there are any other questions that folks would like to pose. We do have a small group session after this where we will have about 10 minutes in much smaller groups to be able to think through this. It's certainly a thought-provoking topic.
So I've got a couple of more of your minutes and you're held hostage. Adrian, the one thing that I could offer is I could share the couple slides around fentanyl.
Yeah.
If you think that might be useful for, okay, let me share my screen one more time. And okay. So one thing, can you guys see this okay? All right. So one concern with the new guidelines that we just published is that we went through this 2-year process of doing a full review of the literature, coming up with the most evidence-based guidelines that we have. And the Academy of Breastfeeding Medicine guidelines say that you should allow sufficient time to pass for substance to clear from the breast milk. But what do we do about fentanyl? I'm not sure about your state, but in our state, the opioid supply is universally contaminated with fentanyl. And we know from several case reports, as well as our own experience of toxicology testing, that fentanyl lingers for a long time. This is a case report that came out of Boston Medical Center, where this is the number of days since the last reported use for this patient. And you can see the fentanyl clears quite quickly, but norfentanyl levels, which often trigger a positive test on the immunoassay, can linger for quite some time. This was up to 90 days. This is another patient at Boston Medical Center. Again, you can see the qualitative presumptive positive that happened in the setting of the last use, and then this kind of lingering, and the norfentanyl levels lingering for quite some time. So, and then this is another case from our colleagues out at Bay State Medical Center. This is Dr. Miller's patient, where again, similarly, now we're going from right to left, going this way, but several months from the period of reported last use to when actually the fentanyl and norfentanyl levels are no longer positive. So what do we do there with respect to breastfeeding recommendations, knowing that fentanyl is the overwhelming drug in our drug supply? And what several colleagues across the country are moving towards is this idea of 5 half-lives of 72 to 96 hours after the last reported use, with a motivated patient who wants to breastfeed, to encourage lactation, to have them pump and discard until they get to the 72 to 96 hour period, and then to support them in breastfeeding. I would say that we, again, with my data-driven hat on, have to do some data collection to understand what really is in the breast milk, in maternal serum and infant serum, and hope one day we can do that study to really understand it. But as of now, many centers are interpreting the current ABM guidelines with what we do know about fentanyl clearance and the half-life, with using 96 hours as sort of a safe time to reinitiate breastfeeding. Yeah, Jennifer.
2 clicks. What about xylazine? I'm not being a scientist, I'm a mental health clinician, so I don't know the chemistry of fentanyl versus xylazine, which we know is also in almost everything.
Yeah, they're totally different makeups, because xylazine is not actually an opioid, but is certainly very sedating and can cause a whole host of other risks to both the parent as well as likely the baby, but we don't know. And so what I would say is we are not testing for xylazine specifically at delivery, at least in Massachusetts. It's in about 25% of the drug supply. So I've got to assume it's in about 25% of the exposures of individuals who had non-prescribed substance use during pregnancy. And I have lots of wonders about this. So I think I'm with you in that I'm wondering, particularly around some of the newborns that have had pretty significant feeding concerns, whether some of that is related to that potential exposure, but we know nothing. And so that's just hypothesizing and trying to understand, at least in our setting, why we're having more infants with pretty significant, profound feeding difficulties at time of delivery. I want to keep you guys on time for the next part of your talk, but thank you so much for the opportunity to talk with you all, to think about this together, and I'm really eager to learn from all of you, and so was so excited to hear about many of the changes that you guys have already made.
Thank you so much for your talk and for giving us all of this information to think about as we go through this, what culture change across our system and across the country in terms of how we manage infants to substance exposure.